Every drop of blood tells a story about healing, about survival, about time. For decades, physicians have relied on lab tests that take too long and reveal too little, leaving them to make life or death decisions in the dark. But two innovators set out to change that. The result was something extraordinary, a tool that listens to blood itself and gives clinicians answers when every second matters.
Bleeding is a very dynamic process, and the sooner you stop the bleeding with the right therapy, the less patients will bleed.
Francesco Viola, founder and chief scientific officer of HemoSonics, a biomedical engineer who used breakthrough ultrasound science that has led to a completely new way of understanding blood clotting in real time. With him today is Dr. Bruce Spiess, a world-renowned anesthesiologist and medical director at HemoSonics.
Bleeding is emotional. As soon as the bleeding starts to happen, the emotions happen.
HemoSonics has already changed how hospitals think about transfusion, trauma, and surgery. But their story began with a simple observation.
If you make the wrong decisions, you make things worse.
And that's where our conversation begins. We have a true titan, Dr. Bruce Spiess, here with us, and we also have Francesco Viola. It's going to be a great conversation. I've known these guys for a bit. I met Dr. Spiess when I was just a baby nurse coordinator. When I first started my job, I don't know if he remembers that. It was several years ago. I came to the University of Rochester and did a talk there, and I was just in awe. It was great. I've known Francesco for a little bit as well. We've worked together on a couple things and just picking his brain. I didn't know I was a coagulation nerd until I met him. So now I know.
Thanks for saying coagulation. That's our topic today.
Thank you for having us on. I remember that visit to Rochester. It was wonderful.
Yes, thank you so much for having us, MaryAnn and Christine. It's a pleasure to be here.
Can you explain a little bit about the different blood components? There's different types of blood products. Sometimes people think it's just red blood cells. Viscoelastic testing helps determine which blood product you might get. Can you talk a little bit about how that helps you determine which product you need and why you don't want to give everything to everyone?
Sure, that's a great question. Let me dive in with that. The standard thing that comes from most blood banks is what's called packed red blood cells. So when you go to donate blood, you give whole blood, which has red blood cells, platelets, proteins, the plasma, and white blood cells, a whole lot of other components within it. But that blood then gets separated into largely packed red blood cells, plasma, which is usually frozen, and platelet concentrates, what's called cryoprecipitate, which is largely one particular protein fraction, fibrinogen, with a few others like pine willibrands and other technical things in there. When they're put in the blood bank, ages. And it's not like a fine red wine or a fine Italian wine, as Francesco. You want the freshest, best stuff you can, really ideally. And when blood transfusion was begun, it was begun using warm, fresh whole blood. And that's what happened in trauma in the First World War, the Second World War, Spanish Civil War and stuff. We've now gone back to that in the military. Every one of our present components that comes from the blood bank carries adverse outcomes. For example, in heart surgery, if you get red blood cells, 10 to 16% increase in death rate per unit of red blood cells you get. If you get fresh frozen plasma, about a 10% increase in death rate. And if you get platelets, 6 to 10% increase in death rate. So if you don't need the blood, you want your own blood, and you don't need somebody else's blood, because you, by getting someone else's from the blood bank, are then sentenced to those risk factors of those outcomes. Trying to understand how physicians have studied it is very complex. But believe me, you want the least amount of those products. You want them in a specific, targeted manner, just what you need. Do we handle all infections by giving every antibiotic we can think of? No, we get one for just what we need. We shouldn't just give everything to everybody and hope that we strike something to make a difference. As I've often said when I lecture, if you're going duck hunting, you don't blow off the shotgun every few seconds to just hope a duck flies and think you're going to hit one. You aim specifically and you know what you're doing.
The shotgun approach, Bruce, that's what our learning was when I started this. The shotgun approach, where it's really clinical decisions where you start dumping product into the patient. So it's called the shotgun approach.
It's really far too common, Denton Cooley, was really one of the key founders of heart surgery down in Houston, Texas. He decided that less blood is good. Don't give a bunch of coagulation products you don't need. He eventually ended up doing thousands upon thousands of heart surgery patients in the 1960s with no blood whatsoever. I would dare anybody to accuse him of not doing good medicine. He's one of the founders of this.
Bruce, I like to think about the donors also. There's many altruistic people out there donating their own blood for all of us to be using on these patients when it's necessary. We really have to think about making sure that we're very respectful of that donor and using every drop of their blood that they have given us appropriately.
The last thing somebody who's donated blood wants to hear is that their blood was wasted. One of the things that we found by using the technology that Francesco created was that we've cut wastage dramatically. And wasted blood is bad for everybody. It's extremely costly. Blood is a homeland security issue. Let's say you're having a bone marrow transplantation and you absolutely need to get platelets because your platelet number is so low. If somebody has wasted all the platelets in the hospital by giving them willy-nilly because it was their clinical judgment that somebody needed platelets, whereas they could have made a specific decision based upon a viscoelastic test, they have now taken and put that second patient at risk because they can't get the e-product they need.
Yeah, it happens a lot more often than people think. We frequently have particularly platelet shortages, and as we have to triage platelets and give them to the sickest people, and then others may have to wait.
Why should physicians and providers and patients talk about patient blood management? Why should they care, especially as it relates to coagulation?
Patient blood management is all about the patient. So often physicians forget that's who they're really dedicated to. As a patient, as a human being, my best blood is my own blood. When I went through medical school, we were never really taught about how to treat blood as an independent organ. But now we're learning more and more that the more you maintain your own blood in you at all times, especially in surgery or major trauma, the better off you'll do. It's not to say that blood transfusion isn't at times necessary or very positive and very life-saving, but if we can find ways to make that happen less commonly, patients do better. They come out of the surgery better. They stay in the hospital less time. They have many fewer complications. And coagulation is a big part of that. If you don't coagulate well, you bleed. If you bleed, bad things happen.
Exactly. In talking about coagulation, how do you determine what's going on in a patient? We've heard this term viscoelastic testing. What does that mean?
Viscoelastic testing is really like a fancy term, but it really expresses a new class of tests that looks at how the blood evolves from liquid to solid. By doing that, allows us to really look at how the various components that are in the blood, they work together in order to allow you to form a clot. As Bruce said before, if you do not clot, you will bleed. With viscoelastic testing, allow us with a small sample of blood to really look at how every component in the blood work together to allow you to form a clot. If you have one of those components is not working, it can be determined via viscoelastic testing so that physicians can target that deficient component alone and not give the patient blood that he or she might not need.
I like to think of it in terms of ecology. Are you looking at the individual trees in the forest, or are you looking at how the whole forest works together? With viscoelastic testing, you're taking a very holistic attitude of, okay, this forest needs a lot of trees. They need to make oxygen. They need to photosynthesize. They need to do all these things they're going to do. Actually, their roots are talking to each other, but they need to cooperate as an ecosystem. And so how does the entire ecosystem work together to make that clot form when you need it the most?
So what you're saying is when somebody comes in and they're bleeding, we don't just throw at them everything we have. We do this test called viscoelastic testing and decide exactly what to give them. Is that what I'm hearing?
Yes, that's correct. That's the genesis of viscoelastic testing. Allows you in these kind of situations where your patient is bleeding to assess which part of your blood is not working correctly so that physicians can optimize treatment and focus only on that component that's deficient.
Is this like a drop of blood, or how is this test done?
Yeah, so tests are typically done with a small sample of blood that's collected in a tube, the same tube that patients routinely get blood collected for a variety of lab tests. There are a variety of technologies out there. They all use a small sample from blood taken in that tube to provide these type of measurements.
I know there's a lot of patients that are out there on like blood thinners. Would this be something you would use for these kind of patients, or how does this differ from the regular blood tests like the PTINR that they get to check their coagulation factors in their blood levels?
Sure. So let's say you're on Coumadin or warfarin, one of the drugs you might take if you have a valve or if you've got atrial fibrillation. Those are very often tested with prothrombin time, INR. That looks at how some proteins work. It is essentially done with artificial activation of plasma. So you take the plasma, the straw-colored fluid, the protein liquid, away from the cells, which would be platelets and white cells, and then you artificially stimulate it and see how long it takes for that to form a initial clot. Other anticoagulants work with other different measures. Some of them work on platelets themselves, but the viscoelastic testing doesn't separate it down into those different subgroups. It looks at the whole population interacting together. One of the things that Francesco has been instrumental in inventing is the ability to run essentially 4 tests at once with different activators and inhibitors, so that the technology, the machine itself, can then take those different activators and inhibitors, use some intelligence of its own computer, and be able to give us a number of parameters that can help physicians then decide what's normal and what's abnormal. There's no absolute specific way to say, if you have this number, you must do this. You still have to know something about the biology that's going on in the patient.
Yeah, that's a great question. Just to maybe paraphrase a little bit what Bruce said, take a step back for a second. The classic coagulation tests have been around for decades now. If you look at them, they're really being designed and developed to monitor specific drugs. Over the years, we have extended their use to look at other things like bleeding or clotting risks. And some of those tests have had some moderate success. However, they were not designed really to manage bleeding patients for a variety of reasons. First, as Bruce mentioned, they are plasma-based. Second, the turnaround time is often very long for those tests. So they are perfectly fine to monitor drugs. That's what they were developed for. If you want to try to understand how to decrease blood loss in a bleeding patient and provide to that patient the fastest care possible, viscoelastic testing is really the best option.
So when you do the viscoelastic testing, is this faster or slower than other traditional tests?
That's a great question, MaryAnn. And as everything in life, right, there are different flavors of viscoelastic testing. Maybe if I take a little bit of a step back, when we started a company, one thing was very interesting to me. This was the times of the cup and pin technologies to do viscoelastic testing, where you would put a small sample of blood between a cup and a pin, and you would see how the two parts move relative to each other. What struck me is there were hundreds of clinical publications that say how wonderful those kind of measurements were. The amount of the type of clinical benefits, better outcomes, and all those wonderful things that Bruce mentioned at the beginning. I often found that those machines were relegated to the closets. So asking why, they really came out to 3 main pillars. And one of which is the one that you just mentioned, MaryAnn. They were too slow, too hard to use, and too hard to interpret. With Bruce and our company, what we have set up to, we got to do better viscoelastic testing and be better than that. So leverage technology and our ultrasound technology to really create something that will achieve all the clinical benefits that we talked about in terms of viscoelastic testing, by doing it in a way that was fast, that was easy to use and easy to interpret. Viscoelastic can be fast, can be very fast, in fact, but not all viscoelastic testing are created equal.
So let me segue off of what Francesco said, because I'm one of the people that is responsible for pushing physicians to say, if you use these mechanical tests, your patients will be better. I'm also a zealot and a little bit of a weird physician anyways. In other words, I will go to the mat to try to make something work. In my hands, it might work, but in 90% of the rest of the world, it won't work. That's why Francesco found these things in closets, is because when you're a very motivated researcher, you can make them work. But when you're a physician on the front lines of a bleeding patient, frustrations of the predicate, the early viscoelastic testing, were overwhelming. And they just couldn't help the physicians make the right decisions. My hat's off to him. When he started working with us, not only did he say, well, let's use ultrasound to look at some basic physics and let's get creative about how we can go about this rather than mechanics, but he said, let's make this so it's readable, it's quick, it's very user friendly, and then maybe we can make a difference to patients.
Bleeding is a very dynamic process, and the sooner you stop the bleeding with the right therapy, the less patients will bleed. They will require less blood products, and they will have less of the complications that Bruce mentioned. Speed is very important.
In my experience, people set up viscoelastic testing for the coronary artery bypass graft that we know is CABG, or maybe trauma. Are those the only instances where this is useful, or can this be for any surgery, or is it only for the fancy ones?
You're correct. Cardiac bypass surgery was one of the early applications of viscoelastic testing, along with liver transplant. Those are oftentimes planned surgeries, and they are well known to generate significant patient bleeding. So those were the two first type of surgeries where viscoelastic testing were used. Ever since, given the success of these technologies, the use has been expanded to other applications like trauma, you mentioned, obstetrics.
We're focused on bleeding. That's what our company is. Their number one mission is right now, is to decrease bleeding and to help patients so that they don't get blood products they don't need. There's an equal and perhaps even worse side, and we saw it with COVID-19, which is you thrombose or you clot. The four of us here and everybody hopefully who's watching is healthy. We're not critically ill, but very quickly patients and biology can go from normality to swing to a far edge one way or the other. So we've provided with this new technology a way to look how far off you are from where the ideal would be. And then it's again up to the physician group to say, hey, with this guidance, I can give the following things to try to get as close back to ideal or normality as I possibly can. Mother Nature doesn't want you to be screwing around with her a whole lot. She wants to stay as normal as possible.
When you're in a situation as a surgeon and you see all this bleeding, it's got to give you a little bit of anxiety because you feel you need to do something. This is why viscoelastic testing is good, because if you throw everything at the patient, you could cause them a problem.
It's a fantastic observation. Bleeding is emotional. Doctors like to think they're dispassionate and they can just be cool, but they're not. As soon as the bleeding starts to happen, the emotions happen. What does emotion in that situation where you're not armed to make the right decisions create? Creates panic. What is panic? I have to do something and I got to do everything and I got to do it all at once. Then hopefully something's going to happen to get me out of this situation. That disaster. Francesco knows that I'm on a personal vendetta to rid the world of fresh frozen plasma. Patients who get fresh frozen plasma bleed more, not less. If you make the wrong decisions, you make things worse.
Why do you think that is? Do you think it's just the dilution effect of the plasma? Do you think it's a bad product? What do you think the reason is that they bleed more when it has coagulation factors in the product itself?
Essentially, plasma has the same coagulation protein concentration as what the four of us have in us right now, we think. But if you're bleeding and you have, let's say, 30% of your normal proteins, and I'm giving you a fluid, 250 cc's, so not a big volume, but I'm giving you that at the normal range. How many volumes of that do I have to give you to arithmetically get you back to normal? I have to replace your entire blood volume. I have to give you at least 3 to 4 liters, Christine, for you to get back to near normal. What do I do when I do that? Then I have to dilute your red cells. To do that, then I have to dilute your platelets. So I'm obligated to give you all those other things. Fresh frozen plasma doesn't have normal protein factors 8 and von Willebrands. So I am obligating you to get you sicker and sicker. One of the things we do know is that if you give somebody fresh frozen plasma, it's the highest chance that they will have lung failure of any blood product. And staying on a ventilator with a tube in your mouth, being breathed on a ventilator creates worse and worse and worse outcomes, not to mention lung infections, pneumonia, et cetera. I personally think, and it's one of the things we've seen when we've researched with Francesco's machine, the Quantro, is that we've seen that fresh frozen plasma utilization drops dramatically and sometimes completely goes away because people now feel comfortable that they can give other things and not have to give that.
We see that routinely, that the plasma proteins that are responsible for clotting are often not the cause of the bleeding. It's been shown viscoelastic testing, and again, it's one of the advantages of these kind of technologies. There are other components that are typically the culprits. As Bruce mentioned, those proteins in the plasma are in so much abundance that you really need to have a lot of bleeding to deplete them to a level that can cause bleeding. Generally, the culprits are the other components in the blood. So FFP should really be used very, very sparingly.
So if you think about like coagulation, hemostasis as like a cup and all these products you're dumping into it. So if you give too much of one, it tips it over the other way. Viscoelastic testing helps with like more precision to know exactly how to balance that as opposed to just like guessing.
Yeah, and as we mentioned before, that's a dynamic process, right? So if you give the wrong treatment, the bleeding continues, and what was deficient gets even more deficient. As Bruce mentioned, you're going to come and go chase your tail. And that's why it's important to be quick and to be precise.
If you intervene at just the right time, you can see, because this is a very rapid test now, you can see whether your therapy improves things or whether the bleeding is so rapid that you need to give more. One of the beauties of this testing is that we can make some pretty good estimates now of exactly how much dose you need of something. So you can anticipate and say, well, I'm going to give this amount rather than I'm just going to give something and see if the bleeding stops. You can give an estimated amount based upon the testing and then retest. And within 5 to 10 minutes, you can have an answer of, did I make the expected effect or not?
Nice. That's much quicker than sending a tube to the lab and waiting for the result.
Yeah.
Yep.
So you know how long that takes? A minimum of an hour.
Now, this is more of a portable device, correct? It's not something that has to stay in a lab, or can it be moved? Can it go into a helicopter? Can you take it places with you?
Yeah, so this is a device that was designed from the ground up to be next to the patient at point of care. It can be moved. It can be rolled into different ORs or different or trauma bay. It can be placed on an helicopter. It's really meant to be next to the patient. That's where you are the fastest.
Interestingly, motion and vibration doesn't seem to really affect it. If you put it on a helicopter, it seems to work just fine. And we've done some vibration testing with it. It's just when the helicopter takes off at a 30-degree angle, you can't be running a test right that minute, but we're still testing that.
If my neighbor is going to the hospital for a planned surgery, should I encourage them to ask if the hospital performs any type of viscoelastic testing?
What I would do, and I know I've discussed this actually with my wife, if I had to have surgery and I'm getting to that age where something might crop up in the next few years, I'm going to ask first and foremost, what kind of patient blood management system have you got? If somebody actually gives me a pretty good answer and we can get into a discussion, my second question would be, for this particular surgery I'm going to have, tell me what my risks of bleeding are. Have you got the most advanced viscoelastic testing to help your physicians make the right decisions? That's where I want it.
It's a great point. Patient blood management, people don't always understand what that means, but the word patient is in there. So you need to acknowledge that what we're dealing with is a person, and everything that we're doing is going to affect them. It's not just about saving money or saving blood. It's about the patients and doing what's right by the patient.
Patient blood management, the newest, latest international definition of patient blood management, starts off by taking and discussing patients, and then second discusses improvements in outcome. So it's those two things. It's not reducing cost. It's not about reducing blood utilization. It's about, let's take the best care of patients that we possibly can. And then all these other things will happen because now we have done the best we can for that patient.
Can you use viscoelastic testing like prophylactically? Is it something that you can test on someone prior to a surgery to see if they're going to be at higher risk for something?
We don't fully understand that yet. We have done, as I've said, we've really focused on the bleeding patient and who's likely to bleed. We can't know yet large populations of who's at the highest risk. Clearly, if you're on anticoagulation or if you have some bleeding risks coming into surgery, that makes a big difference. We need to know more and more about how to optimize people coming into the operation.
Correct.
Just like we're trying now to optimize anemia and iron therapy, and people shouldn't go to surgery truly anemic. You shouldn't go to surgery with a big bleeding risk that we could know and do something about.
I think it's important also to remember that these type of tests have been shown over and over to have an extremely high negative predictive value, but a relatively low positive predictive value. So trying to use them for prediction, like Bruce said, I'm not sure we are quite there yet. I think using them just before surgery to understand the patient profile before surgery is done, I think that makes perfect sense. I think, and that's something that our team works with a customer with, but trying to use the stats as a predictive tool, we're not quite there yet. And likely will involve not just viscoelastic testing, but a variety of other inputs to whatever model we decide to use.
We've covered a lot here today. You fellows have wonderfully explained, broken down very simply for us what is viscoelastic testing and why it makes the best, most appropriate use of the products that we do have available to us, and why it's good to have this targeted therapy for patients. So we're only giving them what is appropriate for them to have. Are there any other takeaways you want to share with the audience out there?
I would just summarize it by saying patient blood management has been called a triple win. The patient wins, number one, the patient don't. The hospital wins because we cut costs, and public health wins because, again, patients do better. If you select a population at risk for bleeding and you take proper care of them, and they spend less time in the hospital, they get out quicker, their return to hospital after being discharged is less. That stands towards public health. So that's a triple win. There's very few therapeutic advances in all of medicine that haven't cost huge amounts of extra money to make the therapeutic advance. This saves money and makes patients better and improves public health.
I feel like often people think coagulation testing and especially viscoelastic testing is like a big monster, right? In fact, viscoelastic testing can be a very strong tool in an effort to create an effective PBM practice. We're proud of what we're done is created a tool that is accessible, it's scalable, and really fulfill some important clinical needs so that at the end of the day, it doesn't sit in the closet, but it is used to help patients.
It actually enhances teamwork. I did years and years of anesthesia for cardiac surgery. And you find out that if people are in the operating room having a disagreement about what therapy they wish to utilize for a patient, and then you bring in a technology that makes all those disagreements go away, all of a sudden the team comes together and says, we know exactly what to do. And we trust each other to make the right decisions. Can we have some pizza and beer and talk about this? You get a camaraderie going of saying, what else can we do next to make this better? The only thing that happens is that patients do better because of it.
I'm an engineer. So for me, sitting on the sidelines has been incredibly rewarding, being part of this journey, being part of this mission, and seeing the success that we have in improving patient care. It's been absolutely wonderful. This has been great. Thank you so much again for having us.